Hey, this is Shannon Finks with the Finks 5, and I have with me Lacey Hinton, who's a fourth-year pharmacy student at the University of Tennessee, and she is going to be talking with us about what she's seen this month in the outpatient treatment of patients diagnosed with COVID-19. We're going to try to do this Finks 5 in 15, but we may actually go a little bit longer than that today.
Here's just a timeline before we dive into the outpatient treatment. So on December 31st, the first cases of COVID-19 were reported in China as a viral pneumonia. On January 9th of 2020, the World Health Organization reported the outbreak in China was caused by a novel coronavirus. On January 13th, the first case of coronavirus was reported outside of China in Thailand. And on January 21st, 2020, the first case of coronavirus is reported in the United States. From this point, the number of cases rose quickly. On March 7th, the cases surpassed 100,000 globally, and the World Health Organization issued a statement calling for the action to help stop the spread of the virus. By April 4th, 2020, over 1 million cases were reported globally. In December, the FDA issued emergency use authorizations for the Pfizer-BioNTech and Moderna COVID-19 vaccines, and on January 20th, 2021, almost a year later, the current cases of COVID in the U.S. are 24,421,994. Globally, it's 96,787,591, and the current deaths are 405,630 in the U.S. and 2,071,892 globally.
It's just been really surreal to be a part and to be a healthcare provider over the past year. This has just been amazing to see and watch and be a part of, and it's something I'll never forget.
COVID-19 or SARS-CoV-2 is a novel virus that may cause symptoms such as fever or chills, headache, shortness of breath or difficulty breathing, cough, nausea or vomiting, diarrhea, sore throat, congestion or runny nose, fatigue, body aches, new loss of taste or smell, and death. Symptoms may appear 2 to 14 days post-exposure.
The strange thing and the hardest thing about being a provider during this time is noting the wide variability in disease presentation, and it can affect so many people so differently. Fever, chills typically being thought of, well, I don't have any fever, I can't have COVID, yet we see about 10% only of our patients who are diagnosed with COVID having fever. I've seen symptoms develop very quickly, and then I've also seen symptoms develop 10 to 12 days post-exposure. And because of the wide variation in symptoms and because of the wide variation in time frame, many patients will be treated differently based upon their symptoms.
Yes, like Dr. Finks mentioned, these patients will be treated symptomatically. However, you should instruct patients to seek emergency medical attention if they have trouble breathing, bluish lips or face, persistent pain or pressure in the chest, new confusion, or if they're unable to wake or stay awake.
Also, if they have a pulse oximeter at home, anything below 90% should go to the ER. They should seek emergency medical attention. And I'll call your attention to the bottom of this slide. There is a COVID-19 treatment guideline that is published and maintained by the National Institutes of Health. It is constantly changing as we constantly learn and gain new information and insight. This is a website that you want to hang on to because by the time you listen to this presentation, some of this information may be outdated. But Lacey's going to go through the treatment of the patient in the outpatient setting with COVID-19.
So first, symptoms such as fever and body aches, these are treated with over-the-counter medications like Tylenol or acetaminophen, 650 milligrams or 1,000 milligrams every 6 hours. It's important not to exceed 3,000 milligrams in a 24-hour period. However, if Tylenol alone won't reduce their symptoms, patients can use Advil or ibuprofen as well. That dose is 400 to 600 milligrams, and they would alternate this with Tylenol every 4 hours. Don't exceed 1,600 milligrams of ibuprofen in a 24-hour period, and NSAIDs should be avoided if there's a history of GI bleeds, cardiovascular disease, or if the patient is taking blood thinners. Cough during the day can be treated with cough lozenges. However, if the cough interrupts the patient's sleep, a prescription cough syrup with codeine may be beneficial. There are many options available, one of which is promethazine with codeine, which is a 5 milliliter dose every 4 to 6 hours with a maximum of 30 milliliters per day.
Of course, patients can also use over-the-counter products with dextromethorphan. We've used Testline Pearls for nighttime relief of cough. There's a wide variety of medications available for symptomatic cough.
Patients may experience some breathing difficulties or some persistent chest discomfort, and in that case, the inhaled steroids are generally used. Budesonide, 0.25 milligrams, 2 to 4 times daily via a nebulizer is what we have been using here. Systemic steroids such as dexamethasone are only recommended in severe cases of COVID-19 and is not for those with mild to moderate disease or those who are hospitalized but do not require oxygen supplementation. Azithromycin, which is an antibiotic that has some immunomodulatory properties, may also be used to help reduce inflammation in the lungs, and the dose used is 500 milligrams on day 1, then 250 milligrams on days 2 through 5.
Our typical patient who has lung involvement will receive both an inhaled corticosteroid via nebulizer along with azithromycin.
Doxycycline is another antibiotic that's believed to work similarly to azithromycin by reducing expression of inflammatory factors, and it may be a better choice for patients who don't tolerate azithromycin or for those at risk for QT prolongation. The proposed dosing regimen is 200 milligrams once, followed by 100 milligrams twice a day for 5 days, and it can be extended to 30 days if symptoms are persistent. Hydroxychloroquine is an anti-malarial drug that also has anti-inflammatory and immunomodulatory properties. It's believed to be a zinc ionophore, and increased intracellular concentrations of zinc may inhibit virus replication by blocking the SARS-CoV-2 RNA-dependent RNA polymerase. It's believed to be most beneficial when started earlier in the hospital course and has been shown in observational studies to reduce progression of disease and prevent hospitalization. And the proposed dosing regimen is 200 milligrams twice daily for 5 days, which can be extended for 30 days for persistent symptoms. However, it's important to monitor the QT interval, especially when used in combination with other QTC prolonging medications.
Yeah, we have years of experience with hydroxychloroquine for malaria. We don't have years of experience with hydroxychloroquine for COVID. And while Lacey did mention some observational studies showing reduction in hospitalization, we also have observational studies showing no difference at all. And one of the reasons that the COVID guidelines don't currently recommend hydroxychloroquine is because of that increased risk for cardiovascular side effects with its use.
Colchicine is an anti-inflammatory medication typically used for gout or rheumatoid arthritis, and it interferes with migration of neutrophils to sites of inflammation. This may be beneficial in combination with corticosteroids to reduce effects of cytokine storm, which is a life-threatening systemic inflammatory syndrome. The proposed regimen is 1.2 milligrams once, then 0.6 milligrams twice a day for 3 weeks. However, this has been studied in hospitalized patients, but not in the outpatient setting. Ivermectin may interfere with the attachment of SARS-CoV-2 spike protein to the cell membrane. It demonstrates some anti-inflammatory properties as well. However, there's been a lot of different dosages used in clinical trials, and some pharmacokinetic and pharmacodynamic studies suggest doses up to 100 times higher than those approved for human use would be necessary to achieve these effects.
Yeah, ivermectin is not recommended currently by the COVID guidelines because of this dosing. Because of unestablished dosing.
Some patients with COVID-19 have experienced microthromboemboli or microclots. It's currently unknown which patient populations are at a higher risk for clot formation, so baby aspirin 81 milligrams once daily for 30 to 60 days may be beneficial. However, it's important to note that there's no research that exists currently on the time frame of when aspirin is most beneficial. It should not be used if the patient has a history of GI bleeds.
We know in the hospital setting that when patients have elevated D-dimers or increased signs or symptoms of clotting, we use full-dose anticoagulation. In the outpatient community, we're not monitoring D-dimer. We're not really sure who is likely to develop clots. We do know that it occurs. And so we have been recommending a baby aspirin in anyone who has risk for cerebrovascular or cardiovascular disease, as well as those with previous history of thromboemboli.
Dietary supplements can be used to help support the immune system during this time. Some of those are high-dose vitamin C, zinc, echinacea, and vitamin D, which I'll go into more detail about each of these in the following slides. Vitamin C has antioxidant properties, and it helps prevent damage to nucleic acids, proteins, lipids, and carbohydrates. A 200 milligram per day dose was used in the studies listed below. One study was performed in hospitalized elderly patients with acute respiratory infections, and they saw reduced disease severity. It's also seen reduction in the duration of the common cold and in symptom severity in some studies, as well as in hospitalized COVID-19 patients, a reduction in length of stay in the ICU, and duration of mechanical ventilation.
Yeah, one comment on vitamin C is that it is fragile in the gut and not a lot is absorbed. That elemental 200 milligrams a day may come from multiple times daily use because you're not sure what is absorbed. But I will say that diarrhea can occur if you take too much vitamin C. So note that patients who complain of diarrhea, tell them to cut back on their vitamin C intake.
Zinc helps maintain, develop, and activate cells involved in immune responses, specifically T cells. It also helps maintain the integrity of epithelial barriers, and it may exhibit some antiviral activity. It's believed that increased intracellular concentrations can reduce the replication of RNA viruses. However, the dose has not been established. The current COVID-19 treatment guidelines does not advise using doses higher than the recommended dietary allowance, which is 11 milligrams for men and 8 milligrams for non-pregnant women of elemental zinc.
We get a lot of questions about zinc because there are some forms over the counter and a lozenge that's even as high as 200 milligrams or 220 milligrams. Just be careful over the long haul of using high zinc without copper. You can develop some interesting elemental deficiencies, and so that high of a dose is not necessary, and I agree with lower doses per the COVID guidelines.
Echinacea has some immunomodulatory effects, and some studies suggest that it enhances our innate immune system by activating macrophages, neutrophils, and natural killer cells. It also has some anti-inflammatory effects and may reduce cytokines and inhibit cyclooxygenase 1 and 2. Many doses, however, have been used in studies, so there's not a specific recommendation at this time. Vitamin D is involved in many processes in our immune system, such as producing and differentiating T and B lymphocytes. It helps maintain the integrity of epithelial barriers in our bodies, and some studies have shown that it can lower the risk of developing respiratory infections. However, high doses are not recommended due to potential adverse effects such as hypercalcemia and nephrocalcinosis.
And remember that vitamin D is your fat-soluble vitamin, so anyone who takes high level or high doses of vitamin C over time should have their vitamin D level monitored.
This is a figure from the Frontiers in Nutrition journal that just shows how zinc, vitamin C, and vitamin D can help support epithelial barriers and protect us from viruses.
And we have a formulation that was developed by an anesthesiologist called our Easy C-Pack out front that combines echinacea, vitamin C, zinc, and vitamin D to be used when someone develops cold symptoms.
It's important to maintain hydration during any sort of sickness. So in some patients, IV rehydration therapy may be considered. The standard therapy used here is 1,000 milliliters of lactated ringers. However, this volume may be less if a patient has heart failure or chronic kidney disease. Another thing commonly used is Infuvite, which contains a full B complex, A, D, C, E, and K vitamins. Patient-specific add-ins are 4 to 8 milligrams of dexamethasone, 30 to 60 milligrams of ketorolac for patients who have persistent pain or fever, and you can do a high dose of vitamin C, which would be 5 to 10 grams. It's typically run over 30 to 45 minutes, and if you are using that Infuvite, running closer to the 45-minute timeline is beneficial to prevent niacin flush.
One of the great advancements of our therapies available for COVID-19 include the monoclonal antibody treatments that are given around the city, currently right now only in a hospitalized setting. And Lacey, we have to refer patients for monoclonal antibody, and there's a specific criteria that need to be met in order for a patient to receive monoclonal antibodies. So why don't you talk us through who meets criteria for monoclonal antibody therapy?
Monoclonal antibody therapy is currently only recommended for high-risk individuals who are not hospitalized, do not require oxygen supplementation, have at least one mild or moderate symptom, and are within 10 days of symptom onset. In order to be considered high risk, a patient must meet one of the following criteria: BMI greater than or equal to 35, have chronic kidney disease, diabetes, or immunosuppressive disease, currently receiving immunosuppressive treatment, greater than or equal to 65 years of age, greater than or equal to 55 years of age, and have one of the following: cardiovascular disease, hypertension, COPD, or other chronic respiratory disease. 12 to 17 years of age and have one of the following: a BMI greater than or equal to the 85th percentile for age and gender, sickle cell disease, congenital or acquired heart disease, neurodevelopment disorders such as cerebral palsy, medical-related technological dependence such as a tracheostomy, gastrostomy, or ventilation, or chronic respiratory disease that requires daily medication for control. Bamlanivimab is the monoclonal antibody currently being used in the Memphis area. It's a recombinant neutralizing human IgG1 kappa monoclonal antibody and is unmodified in the FC region. Its emergency use authorization was granted by the FDA in November of 2020, and the dose being used is 700 milligrams IV over 60 minutes. It binds to the SARS-CoV-2 spike protein and prevents attachment to the angiotensin-converting enzyme 2 receptor.
So it binds to that spike protein and doesn't allow it to replicate in the human body. It's amazing. Just one thing to keep in mind, these therapies are not without risk, and some of our patients develop hypotension when they receive these infusions. You can have infusion-related reactions. You can also have a spike in temperature as well, and so it's very important for them to be followed and have physician care or provider care during the time. But most of our patients who have received the monoclonal antibodies have done very well 24 to 48 hours after the infusion.
The next few slides just have some important education points for patients. So the first thing is just to maintain proper hydration, whether that's considering IV rehydration therapy or just reminding them to drink plenty of water throughout the day. It's important to rest whenever possible, especially for those who are experiencing that fatigue as a side effect. And patients who have diabetes should monitor their blood sugar more frequently because infections can cause their sugar to be higher or lower than normal.
One of the things that I'll say about rest whenever possible, we always get questions about exercise. When can I resume my regular exercise regimen? And the answer to that is carefully, because COVID can affect both lungs and heart. You don't want to overdo when you're re-entering after your quarantine time. And the American Academy of Pediatrics has actually put out a statement saying that any athlete who is recovering from COVID must have an EKG prior to returning to school sports.
It's important for patients to help maintain proper hygiene to prevent the spread of the infection. So washing hands with soap and water for at least 20 seconds or using an alcohol-based hand sanitizer often, and cleaning and sanitizing surfaces. The patient should isolate for a minimum of 10 days and must be fever-free without fever-reducing medications with symptom improvement for at least 24 hours. Household contacts must quarantine for as long as they are exposed. If the contact can isolate from the patient, their quarantine may end after day 7 if no symptoms and test negative after day 5, after day 10 without testing if they are not experiencing any symptoms, or after day 14. But it's important to self-monitor for symptoms up to 14 days post-exposure. This is just some guidance from the Tennessee Department of Health. The top one is just for patients, which is what we stated on the previous slide, that 10-day minimum with the 24 hours without fever or fever-reducing medications and symptom improvement. And the second is for household contacts. However, the Tennessee Department of Health has a longer quarantine period at 24 days. Because it doesn't start until after that 10 days minimum of the case completed minimum isolation, and then begins with the 7 days or 5 after testing negative to the 10 and then the 14.
So the Tennessee Department of Health has not updated its guidelines since the CDC shortened the contact exposure, but the CDC guidelines that have shortened that time frame do not account for a daily household contact. And so there's a wide range of how you interpret these guidelines. We tend to work with patients and determine the isolation of the patient with COVID and then help those household contacts navigate how best to re-enter themselves. But as Lacey said on the previous slide, it is very important because we've seen symptoms develop at day 10, day 12, to monitor those symptoms out to 14 days after exposure. I want to thank Lacey for this wonderful presentation. She's experienced all of this on rotation, but she's really done a great job of pulling all together what we currently know, and we have seen constant change with this illness, and we refer you to the National Institutes of Health for current and contemporary guidance on the outpatient treatment of COVID-19.